Rheumatoid arthritis is considered to be a systemic disease which is very highly characterized by symmetrical inflammation of joints. However, one has to be clear that it may involve other organ systems as well. It is the most common systemic inflammatory disease that is characterized by symmetrical joint involvement. And quite often extra-articular manifestations may also be present in a number of your patients. The chronic inflammation of synovial tissue which lines the joint capsule results in proliferation of this tissue. As the synovium continues to proliferate, it will invade the bone, and once it invades the bone and starts to destroy the cartilage, this is referred to as the pannus. This often happens to immune dysregulation, which is one of the most probable causes of rheumatoid arthritis. It may also be promoted or triggered by genetic predisposition, age-related wear and tear, hypothermia, and underlying infection. Subsequently, as the proliferation continues, the synovial lining continues to thicken and stiffen. You have ongoing proliferation, expression and upregulation of fibroblasts, and the stimulation of inflammatory cells and prostanoid production. This causes an influx of the inflammatory cells into the synovial fluid, and this induces the inflammatory cascade. The pathophysiology behind rheumatoid arthritis is much more complex, and due to the immune dysregulation, this causes an upregulation of the T and the B cells, the pro-inflammatory cytokine, particularly interleukin 1 and 6, the CD4 cells, and also other pro-inflammatory cytokines, and the stimulation of metalloproteinases, upregulation of fibroblasts, which causes also lysosomal enzyme release, which destroys the cells. Due to the immune dysregulation, you have the accumulation of T lymphocytes, which stimulates release of macrophages and releases the inflammatory cytokines, particularly interleukin 1 and interleukin 6. This releases enzymes that will cause connective tissue degradation and stimulation of B lymphocytes, and subsequently produces rheumatoid factor, RHF. One of the other diagnostic features in your patients is the production of rheumatoid factor. 70% of your patients will come back positive, and also the expression and the presence of C-reactive protein. The pro-inflammatory cytokines are TNF-alpha, interleukin 1, interleukin 6, and interleukin 17. The stimulation of synovial fibroblasts will cause release of matrix metalloproteinases, which causes further joint degradation. Now, typically in your patients, you must also look for extra-articular manifestations. While the typical diagnostic features will be lack of mobilization, joint stiffness, usually in the joints of the arms, wrist, and hands. For 30 minutes in the morning, they may not be able to mobilize themselves. It is important to look for other extra-articular manifestations. One is the rheumatoid nodules. 20% of patients will show up with this in the extensed surface of the forearms. And as this continues, you have the synovium becoming inflamed, producing excess fluid, and then it destroys the cartilage. And the rheumatoid nodules also become significant in patients who are older. The other thing is, in these patients you will see vasculitis, which is obliteration of blood vessels, particularly around the vessels of the nail beds. The next thing that is important is cardiac manifestations and pulmonary manifestations, and also splenomegaly, which is not only enlargement of the spleen, but some patients may develop thrombocytopenia. As a result, the treatment of rheumatoid arthritis requires aggressive therapy, and you need to relieve the pain. You need to immediately reduce the inflammation and the chemotaxis and the accumulation and overexpression of T and B lymphocytes, and antagonize the interleukins. You need to protect the articular structures and maintain joint function, and also control the systemic involvement and infection. As a result, the treatment of rheumatoid arthritis requires aggressive therapy. The first-line drugs and the drugs of choice are DMARDs, or the disease-modifying antirheumatic drugs. Many years ago, they were referred to as SARDs, slow-acting antirheumatic drugs. And they are indeed slow-acting, and for this particular reason, therapy has to be instituted quickly. As mentioned in the NSAIDs lectures, the non-steroidal anti-inflammatory drugs do nothing to retard joint injury. They are basically used as an adjunct to provide a little bit of analgesia and pain relief. In flare-ups, glucocorticoids may be used, and should DMARDs fail, then biological response modifiers is your drug of choice. NSAIDs are initially used to control the initial inflammation and pain. Low-dose oral glucocorticoids such as prednisone may retard the disease progression. DMARDs are the first-line therapy for patients with aggressive disease. If it is caught early on, the DMARDs may reverse joint degeneration. A combination therapy may be required for optimal results and prevention disease progression. The acute relief of inflammatory symptoms may be produced by NSAIDs such as indomethacin, diclofenac, piroxicam, and ibuprofen, together with glucocorticoids such as prednisone, but they will not halt the progression of the joint destruction. Disease-modifying antirheumatic drugs must be initiated within the first 3 months of diagnosis. You can use a single or combination DMARDs to prevent joint erosion. NSAIDs will provide some degree of analgesic relief and anti-inflammatory benefits, but will not change the progression of the disease. They will inhibit cyclooxygenase activity and reduce some degree of inflammatory mediators, but you must always use them in conjunction with DMARDs. As a result, the NSAIDs will inhibit neutrophil activation, some degree of chemotaxis and leukotriene production, and by inhibiting the inflammatory cascade and slowing it down, they will indirectly inhibit T and B cell proliferation. They will also interfere with membrane-associated processes which will oxidize neutrophils and will also reduce the activity of phospholipase C in macrophages. These are the choices of your NSAIDs that we had discussed previously in the non-steroidal anti-inflammatory drug section. The glucocorticoids are much more efficient than NSAIDs for management of pain and stiffness, but you cannot use the glucocorticoids chronically due to the significant side effects. Usually 7.5 milligrams of prednisolone daily will significantly reduce the occurrence and progression of erosions. Intra-articular instillation with caution, you want to avoid infections like triamcinolone, methylprednisolone or betamethasone into the swollen joints may also help. Glucocorticoids can be used as continuous oral background therapy or as large oral pulses or short courses of rapidly decreasing doses for disease flares, and as intra-articular injections and as IV pulses during a flare, and also as induction treatment when you commence DMARD treatment. As indicated, disease-modifying antirheumatic drugs are first line. They will inhibit the pro-inflammatory cytokines, they will prevent chemotaxis, and they will prevent cell proliferation and activation of the interferons and tumor necrosis factor. They are extremely slow acting. They take a while to accumulate in joints, have a very slow steady state. Therefore you may see anywhere from 6 weeks to 3 months to see some degree of benefit. DMARDs do not have any direct analgesic activity. Any analgesic activity they do provide is indirectly by inhibition of the pro-inflammatory mediators. They are first line to rheumatic disorders and will slow the course of the disease. The drugs of choice are methotrexate is the drug of choice, first line. Sulfasalazine may be added on to methotrexate, and then the other two drugs are hydroxychloroquine. And methotrexate basically inhibits both purine and pyrimidine synthesis, and by doing so will reduce the inhibit dihydrofolate reductase and therefore reduce lymphocyte proliferation, inhibit chemotaxis, and reduce RHF production and cytokine production, and it is the DMARD of choice. It will reduce the progression of the disease. Continue use of the NSAIDs unless remission occurs. It's usually given as a weekly dose until symptomatic improvement occurs, plus supplemental folic acid. Usually we start with monotherapy and then sulfasalazine may be added on if inadequate responses are given. Patients must avoid alcohol and take folic acid as directed. You must monitor liver function because there have been serious adverse effects such as hepatotoxicity and pulmonary fibrosis, which is also a dose-related problem. Hydroxychloroquine, which is an anti-malarial drug, is extremely slow acting. It is very seldom used, only in moderate cases, and it basically to a certain degree inhibits lymphocyte function and will stabilize lysosomal membranes, reduce chemotaxis and phagocytosis, and reduce the production and release of interleukin-1, but it is very slow acting, has low efficacy. Problem is that it has a long elimination half-life, takes 6 months to reach steady state concentrations, and this is what has such a delayed effect. Sulfasalazine may be added on to methotrexate. It is converted in the intestine by gut bacteria to sulfapyridine, which is antibacterial, and mesalamine, which is a version of 5-acetyl salicylic acid, which has anti-inflammatory properties. It will inhibit the production of prostaglandins. However, it may cause some degree of GI effects, so one has to exercise caution. Leflunomide can also be added on. It inhibits dihydrourate dehydrogenase and therefore will inhibit T lymphocyte responses. It is metabolized to an active metabolite which has a very long half-life. It's usually given with a loading dose followed by a maintenance dose. You can use it in combination with methotrexate, but one has to be cautious because you run a high risk of hepatotoxicity. It is contraindicated in hepatic dysfunction. Now, should your standard DMARDs fail, then you need to move on to the newer recombinant drugs, or the monoclonal antibodies, often referred to as the biological response modifiers. These drugs were extremely expensive when they first came out in the market. While their costs have still dropped, they're still fairly expensive. They can be combined with the DMARDs, used as a replacement for the DMARDs. They are categorized as the TNF antagonists, particularly etanercept and infliximab. There is only one interleukin receptor antagonist, anakinra, co-stimulation blockers, abatacept, and an anti-CD20 monoclonal antibody, rituximab. Etanercept will prevent the binding of TNF to receptors. It's given subcutaneously twice weekly, has a long elimination half-life, and has shown to be effective as monotherapy. Most of the biological response modifiers have shown an effect within 2 to 3 weeks. They may be combined with the DMARD except for anakinra due to side effects. All your biological response modifiers will cause injection site reactions. They may cause immunosuppression and basically infections. Infliximab is an Ig1 monoclonal antibody. It solubilizes TNF, and it's given via IV infusion over a period of 4 to 8 weeks. It too has a very long elimination half-life, and you quickly see a fairly quick symptomatic relief. Adalimumab will prevent the binding of TNF with the receptors, so it's a TNF antagonist, and will also lyse TNF expressing cells and reduce the production of TNF alpha by macrophages. It's given SC administration every 2 weeks and has a mighty long half-life as well. You will see a symptomatic relief within a week. It's used as monotherapy. It can be combined with DMARDs. The adverse reactions, like all the other biological response modifiers, is immunosuppression and infections. Anakinra is the only interleukin receptor antagonist and will prevent the binding of interleukins. It is given via daily SC administration and can be used as monotherapy or combination of DMARDs. They are contraindicated with TNF antagonists because of increased risk of immunosuppression and infections. Abatacept will block the signaling of T cells and activation of T cells, and is given IV over 30 minutes every 4 weeks, which could be a hassle, and abatacept will also cause a lot of injection site reaction. It also has a very long half-life. These long half-lives actually are also responsible for the efficacy of these drugs, and due to the fact that because of the long half-life, they're able to accumulate within synovial fluid. Abatacept is contraindicated with TNF antagonists and anakinra and will cause the similar reaction side effects of all the other BRMs. Rituximab will deplete B lymphocytes and will maintain a sustained depletion of B lymphocytes. It's given IV over 4 hours initially, then every 2 weeks. Look at the half-life, 60 to 150 hours. This is why the therapeutic effects will last for at least 40 weeks after initial treatment because of the extremely long half-life. Can be used as monotherapy or combination with methotrexate. Problem is, apart from the other standard side effects, rituximab may cause angioedema and significant hypotension. Therefore, antihypertensive therapy in patients who are receiving antihypertensive therapy should be withheld at least 12 hours prior to the administration of rituximab. When using the BRMs, they are contraindicated in immunosuppressed patients and patients who have infections. Use with caution in geriatric patients. They will be more predisposed to infections, and particularly in HIV/AIDS patients. So you need to start early aggressive therapy. Once it's diagnosed, combine NSAIDs and DMARDs, low-dose systemic corticosteroids, and if this is insufficient, combine the DMARDs or the BRMs. Try and establish diagnosis early with all the markers, together the markers such as RHF and C-reactive protein, and start on the DMARDs. If methotrexate is insufficient, add on another DMARD. If that does not work, then these patients are usually good candidates for biological response modifiers.